All right, so again, welcome everybody. Been looking forward to this one for quite a while. Really appreciate Keitha and Maghan and for helping share this information today on family preservation and family first prevention services. So Keitha, I'm going to go ahead and hand it over to you. Keitha's with Oklahoma DHS and with the administrator for the family first prevention services. Maybe describe a little bit of what that means as well. So I'm going to go ahead and hand it to you.
Sure, thank you. As you mentioned, I'm Keitha Wilson, and I am with DHS, Child Welfare Services. And in 2018, the Family First Prevention Services Act was passed. And although it didn't happen right away, a few years later, then DHS named me the kind of be all end all over Family First for DHS to make sure that we were meeting all the federal regulations towards that, as well as towards the Family First Prevention Program Plan that is optional. So today we're going to talk a little bit in general about Family First Prevention Services Act, but we're going to focus primarily on one of the main provisions that we'll talk about more so that involves the court system that would directly involve what you're seeing in your role as the PARB. So Family First, as I mentioned, was passed in 2018, and it is really aimed at a broader vision of changing the national child welfare practice, focusing on the strengthening families and communities, recognizing the importance of working with children and families to prevent unnecessary foster care placements. So that's one of the key things with Family First is it's not necessarily preventing maltreatment, but really preventing foster care as the intervention needed for families that have had abuse or neglect happen to them. And really focusing on providing opportunities to states to really think about how they were going to improve serving children and families. So not adding additional entries into foster care, looking at the quality and availability of services, and even when they enter care, what that quality foster care looks like, encouraging and supporting kinship care. So there's pieces of the legislation that focuses on kinship care, particularly if you guys are familiar with hearing about kinship navigator programs, which we do have one in Oklahoma as well. Increasing the unnecessary use of congregate care, and again, improving the overall quality for children if they are utilizing congregate care, which is what we're going to focus on for today. But this really aligns with what DHS was already moving towards with our vision and mission. Several of you have heard Director Brown talk about our True North goals, and each division develops their own goals, which you'll see on this slide, which is the Child Welfare Service True North goals. And really our vision that we created in partnership with our sister agencies was to promote strong Oklahoma families together. And this really aligns with our strategic priorities around prevention services, family-based placements, the quality of if there are non-family-based placements or congregate care or what we consider kind of our higher level needs placements, looking and making sure that we have evidence-based programs and services available for children and families that we serve, and really taking into account building the capacity and leveraging the resources needed to serve and prevent foster care placements. So really looking at how can we braid the funding available within our state to ensure that we're able to maximize on serving children and families. So there really are two major provisions of the Family First Act, one of those being on the prevention side of things. So this was not new money per se, but it is an optional program for states to put into place and get approval for prevention services to serve families outside of foster care. So this is not, again, looking at necessarily primary prevention where we're looking at trying to prevent maltreatment, but really looking at how can we prevent children from entering foster care and being able to serve families preventively in their own homes. DHS has been doing this for over a decade now already in our family-centered service program. And so this isn't necessarily a new thing for us, but it is certainly some things that we had to meet federal regulations to be able to draw down the federal 4E funding stream that pays for foster care to actually then pay for preventive services for those families in the prevention family-centered service care. The other provision of Family First is to improve the quality of foster care. And again, that's what we will focus on today because that directly relates to some federal requirements around this for the courts, which again, you'll be seeing as you're reviewing cases. So really this provision is looking at making sure that we decrease the unnecessary use of congregate care, what we consider our group home care in Oklahoma. And if children do need to be in that level of care, and we'll talk about how we're determining that in our system moving forward and meeting the federal regulations, ensuring that those are of quality care. All things that DHS has been working towards with our continuum of care efforts, as well as through our Pinnacle Plan settlement agreement efforts to improve the quality of foster care. So I'm going to turn it over to my colleague, Maghan Ruark, and she's going to talk about the specifics around the pieces of the improving of the quality of foster care piece. And then we'll bring in Dr. Wilsie to talk about the assessment, the part that I mentioned that we would be determining how children are going to enter our congregate care settings and meet the federal regulations to that. So Maghan, are you ready?
Yes, thank you, Keitha. Good morning, everyone. My name is Maghan Ruark, and as Keitha said, we work together in child welfare services. I'm specifically the program administrator for permanency planning and prevention services. So from the prevention side of things, very excited about this act, the different things that we have to offer for these families, but also for those kiddos who are in foster care, there are those additional provisions which Keitha just mentioned, which we're equally as excited about, which is improving the quality of foster care. Really trying to get our staff and our workforce to think about congregate care specifically as treatment-based. You know, for so long when we talk about group homes and things like that, we think of it as that was the placement at that time that we felt like we had available. We want our staff to think about treatment-based and trying to get all children in foster care into a family-like setting. So as you heard Keitha just mention, continuum of care, we do have a program administrator specifically designated to that program. Her name is Maghan Ruark. She will be the one really leading the charge with the continuum of care. And this is a piece of that. So Keitha, next slide. So again, what is this provision, part of Family First for kiddos in foster care? Well, it's ensuring the necessity of a placement that is not in a family foster home. So when we have to look at a placement that is not in a family-like setting, we want to make sure that we have our checks and balances there to ensure that this child, if they are going into this congregate care setting or anything above a family-like setting, it is in that child's or youth's best interest. The act began in October of 2019 when it passed and when Oklahoma started really talking about that when Keitha came on board, but we had the option to delay, which we chose to do until 2021. So Keitha has been working very diligently with community providers and stakeholders trying to tie all this together. This will begin in October of 2021. Specifically for this population of children that we're going to go over with you here in just a second. So as you start reviewing cases beginning in October of 2021, hopefully there will be some language that you will see in court reports and court hearing documentation and things of that nature, which we'll go over as well. So I just really want to point out October 2021 to you for you guys. So when you start reviewing cases, you think of that time frame. So what all is included for these kiddos who are in foster care? Well, there's a couple different things that we're able to draw down these $40 for, and Keitha has it listed out for you guys right here. The facility for pregnant and parenting youth, supervised independent living, family-based residential treatment facility for substance abuse. These are different opportunities now that we have the ability to draw down 4E funding for. As Keitha previously kind of talked about a little bit, this isn't a new funding stream. It's just a different way that we can draw down for children who are in foster care. But the big one that we're here to talk to you guys today about is this Qualified Residential Treatment Program, or known as QRTP. QRTP, it's not new group homes. It's a subset of licensed group home care facilities. It doesn't wholly replace those group homes that we previously had. So I'm going to kind of go into what exactly is a QRTP placement for these kiddos in congregate care settings. All right, so here we have the QRTP requirements and descriptions. So we have been doing a lot of contract modifications with these group homes, looking at what they previously provided in care for the group homes. Keep in mind, this will be for group homes level C, D+, E, and E+. That is specific, this information that you see here, specific to those group homes. So they have to have trauma-informed treatment models to really assess the needs of that youth, including any clinical needs that they deem appropriate. They have to be licensed and accredited. Our group homes were previously licensed, but now they have to be accredited, showing we have all these things in place to be qualified as a QRTP placement in order to draw down that 4E funding. They have to have a 24-hour nursing and clinical staff available for the youth. Keep in mind, depending on what group home this might look a little different. One group home might have someone specifically on site to assist if there needs to be an assessment of some sort. Some might have that clinical or nursing staff available 24/7 via telephone. So it will look a little bit different, but just know that this is something that the group homes are required to produce if they are going to be a QRTP placement. Family engagement. I spoke to this group, it was last week or the week before. We are really hitting hard with our staff on family engagement, because we know that the more engaged that youth's family is in treatment planning, talking about short and long-term goals, the more successful that youth is going to be to get to that next place. So our staff have what they're responsible for in terms of family engagement, but the group homes will also have someone designated to assist with family engagement. So if the youth gives a contact, hey, I want to put this person on my phone list, the group home has to make diligent efforts as well to work with child welfare to get this youth connected to the people that they deem as maybe someone, a connection or something like that. Part of that family engagement will be increased family meetings. So having the permanency team come to the table as well. This next piece, which is really pretty awesome, is the 6-month aftercare plan. So upon discharge planning to a family-based setting, there has to be at least 6 months post-discharge support for that youth and their new placement. So no longer are we discharging youth from congregate care and then the worker trying to find services and kind of get them set up with, I think this is what would be best. They now have this team that's going to help with that aftercare planning for 6 months. And I see Keith put a question in the chat. Do we see the number of QRTP homes expanding? From my understanding, and Keitha might have a better idea, but the number of group homes, I believe, remains the same. It's the same group of group homes that we had. It's just some are choosing to become QRTP certified. Keitha, is that correct?
Correct. We're, as a state, our aim is not to increase the number of group home care available, but ensuring that the number that we have is of quality care, because we know that children do best in family-like settings. So we are actually looking at how can we increase efforts to have more family-based care. But we do understand that children there is a subset of children that do require this level of treatment. And so for those that do, we want to make sure that we have the quality treatment available. And that's what Dr. Wilsie will go into a little bit further on her part.
All right, next slide, please. Okay, is Dr. Wilsie on here?
Yes, I'm here.
Okay, all right, I'm gonna hand it off to you.
Hi, good morning. We're so glad that we can come and talk about this process with you this morning. My name is Carisa Wilsie, and I'm a licensed psychologist at OU Health, but I work closely with DHS on lots of aspects of improving child well-being, this being one of them. And we're excited to start in this kind of new process of what's going to be happening through QRTP. So part of the issue that the federal government wanted to address is they wanted to make sure that they took out any bias from deciding on if a child should be placed in a treatment program that would be residential, so what we call our group homes. And in doing this, they wanted to look at, is this appropriate for the child, by using an evidence-based assessment, but by having a place where we can step back and have a third party do it. There's been debate for a long time on if DHS is the one that assesses a child. There may be some bias in thinking if this child should or shouldn't be in this placement. If the provider does it, there's also some bias on, well, we've got a bed available and that helps us, or we don't have a bed available, so it wouldn't help us. So the federal government, in putting together Families First, wanted to use a third-party assessor to step in and be somebody outside of DHS and outside of the providers that can look at a child and use an evidence-based assessment to make determinations of if they're appropriate in a group home. So by law, this needs to be done within 30 days of when the placement is made. In Oklahoma, our goal is to have this done before placement is even established. What we don't want is for a child to go somewhere and then we do the assessment and that child to have to be moved again. So our goal is that we're going to have these done quick enough that they can be done in making those placement decisions right away. And then they're going to be used in the court determination. So it will be done within 30 days. And then they go before a judge within 60 days to determine if the child is appropriate to stay within the placement in the group home. Through the 30-day assessment, there's lots of different aspects that go into it, but really the biggest part of it is we're using the CANS. That's the acronym for the Child and Adolescent Needs and Strengths. So this is an evidence-based tool, meaning that it's been used in lots of different research situations and found to be effective in lots of different ways. It's trauma-informed, meaning that it's looking at the background of a child and really incorporating the fact that their background is based in that they've experienced child abuse and neglect. It's used primarily as a communication tool, not as a diagnostic tool. So typically when a child receives an assessment from somebody, a psychologist or somebody in the behavioral health team, it's looking at, let's diagnose a child so that we can use that as a communication across the team. However, the CANS doesn't work to diagnose a child. Instead, it's identifying needs and strengths. And the goal of it is to communicate across the team so that everybody knows information about a youth, so they have all that information in making a determination. So it's intended to aid in these placement decisions and inform these case plan decision-making, the process that happens. So we'll be administering this CANS, and then by using kind of an algorithm that's already set up, we'll be looking at the most effective and appropriate level of care for a youth. Our goal is always to keep that consistent with the youth's goals and what the permanency plan is for that youth, as well as the least restrictive environment. So by taking into all that into effect, we'll be using the CANS to do this. Go to the next slide. The neat part about the CANS is that it takes a lot of different aspects and then puts it into what the rating is. So again, with a typical diagnostic tool, you hand a piece of paper to a parent or a caregiver or somebody that's involved with that child, and they fill it out by rating the child themselves on an instrument. Instead, what the CANS does is the administrator, the person, which is going to be this third-party person, whom we call, according to Family First language, a qualified individual. So the qualified individual will be interviewing all the people that are involved in the youth's life that are, pertinent to the case. So particularly the youth themselves, as well as if they're already in a treatment facility, then they can be looking at interviewing somebody that they see day to day, or the foster parent that they're already with. If they're in the foster home, a bio parent, if that's already has that bio parent involved in their behavioral health treatment plan and permanency plan, as well as the child's worker. And so by taking all these voices and looking at a review of the records, then they take that instrument and they're going to be rating them according to that. So it's looking really across a lot of different domains, incorporating all these voices and putting that together. Then the ratings kind of determine the level of need that is communicated across the team. You can go to the next slide. The different domains are life functioning, strengths, cultural factors, caregiver resources and needs, if there is a bio parent involved that needs to be caring for this child, behavioral and emotional needs, and then risk behaviors. So all these different domains kind of go into one assessment, and we can look at all these different factors, but each of those domains have individual items with them. And so all those items are used in this algorithm. And this algorithm is looking at, is it a high level need or is it a strength that we need to be developing? So it's on a rating 0, 1, 2, or 3, and needs we're looking at a 2 or a 3. So if there are these high level items that really require action and really a need right away, then that's when we're going to be utilizing those and making those decisions. On the strengths, it's opposite, where we're looking more at the 0s and 1s, where is this a strength that we need to be using to plan? Is this something that is really important with the youth that they can draw upon to be successful in a placement? And then again, we're going to use all of those things and use this algorithm. So this is going to be done for a child. And really, today we're focusing on group homes, but we're actually doing this for all kids in higher levels of care at any level. So not just our group homes. So it's going to be a really continuous and seamless process at looking for, if a child is not maintained in traditional foster care, where do they need to go? We can use the CANs, and we're going to be developing the CANs for all those different levels, not just our group homes. But we'll be doing that right away whenever the placement is being requested. So within 3 business days, we're going to have a report ready for everyone who's involved in the child's plan. That report will go into the court reports that'll be used. And so anything that anybody's reviewing will be a part of that, as well as it's going to be in our kids' system. So anyone in the child's case will be able to have full access to this information as well. Because again, this information is about communicating, right? So this communication will be open and available for everybody that's involved in this child's case. And then we'll do this every 6 months, so that if a child is in a group home, we want to continue to assess, are they appropriate to continue living in that group home, or do they need to step down, or maybe even step up, depending upon the request made by the providers. So with that, we'll be doing it every 6 months or every time that there's a placement change needed. Now, if they've been in a placement for 2 weeks and there's a change requested, then there's not much to update. So it would be a really quick process of just updating, what's happened in the last 2 weeks. They may change some ratings, or it may be that nothing's really happened for other reasons. This placement needs to change. And so because of that, there won't have to be another CANS. But anytime within the 6 months, if there's a placement request and there's things that have changed, we'll be doing a CANS, or we'll be doing them every 6 months for the kids while they're in care. So we'll be starting this. We're working on getting all the contracts signed, and we're working on getting everybody ready to be hired to do this. It'll be a team underneath me, hired through OU Health. So I'll be supervising them and watching them really closely in their training to make sure they understand all the aspects that go into caring for our youths in child welfare. And so we'll be starting this as soon as possible, but definitely by October 1st, as Maghan talked about earlier. So I think that's all I need to cover, but Keitha or Maghan, please let me know if there's anything else I should cover.
No, that was all the slides for that, but I just thought we might want to pause for a minute and just see if anybody had any questions specifically on the cans. Before
Great,
we
yeah.
move.
I do. So who else is going to be getting the cans? Is it just a particular group? Is it the residential care folks? Or
So
what is that?
like we'll receive the information. Is that what you're asking?
No, the assessment itself. Does everybody get the cans right now?
So what we'll be starting is for any child that has a request for enhanced foster care, therapeutic foster care, intensive treatment family services, or group homes, particularly our levels, looking at our levels D+ and E, and E+. Those are the kids that will be receiving the cans starting as once we get started. So any request for a kid at any of those levels is going to be receiving cans. Great question.
Did that answer that for you, Keith?
Yeah. And so you're going to be a kind of an independent group, though, kind of like the mental health consultants. You'll be, people will reach out to you guys, to workers, individual workers, and say, hey, we're looking at a higher level of placement. Can you perform the cans for these folks? Okay. And I know back in the day, I always do this, Marsha will attest to that, but you know, the cans used to be used a lot with the wraparound, kids in wraparound. Is that not the case anymore, or is this not used that much anymore?
It's not utilized widely in Oklahoma. We're not aware of any statewide programs using it, so I don't think the wraparound program is using it anymore. They could be, however. However, the good part is if a provider does use the cans, it's not the type of assessment that is limited where you can't do it again. You know, with some assessments, the more you do them, you're not able to do them multiple times. However, with the cans, it can be utilized as many times as needed. So there won't be any problems if anybody else in the state does use it for a child. But at this point in Oklahoma, it's not widely used. However, it's widely used in multiple other states, particularly in their child welfare systems. And I'm working closely within a group that's doing that in other states so that we can help each other and kind of talk through issues of how to do this and how to implement this. And so I am learning a lot from the other states.
Oh, and it's 4E money that's going to help pay for this?
Mm-hmm.
Okay.
So as part of Families First federal regulations, we have to have this assessment done for all kids in QRTP placement settings, which essentially all of our group homes will be QRTP designations outside of the developmental disabled RDDS placements and more of our hospital-like setting residential. But all other group home care have to meet this QRTP designation to then allow us to draw down those 4E foster care dollars to pay for children in foster care, which is, you know, the room and board and treatment and such for when they're in these congregate care settings. So part of the federal regulation is we have to have this assessment built in to show that they need this level of placement.
So a PARB recommendation could be, it sounds like this child might need a higher level of care. We recommend that a CANS be administered to see what additional services are needed or something like that. That sound right?
Yeah, so I mean, you would definitely be in line to be recommending that. So anyone is recommending a higher level of care would be, able to access the ability to request a CANS as well. The process of a worker requesting that higher level of care that's what's going to trigger the CANS. So through the different levels, when they get that request for that level, that will kind of trigger our team to do that CANS.
Gotcha. That's good to know. And you may not be that familiar, but this group is with the Post-Education Review Boards. Our purpose for existing is to look at the case and see if we can identify issues that we think the judge should address or recommendations to the judge.
Yeah. Keith, I think for the purpose of PARB, a good recommendation would be explore higher levels of care for treatment, including the CANS assessment to determine best placement for this child. So, yeah.
I have a quick question just to clarify. You mentioned that the 4E funding wasn't new funding, and I just want to clarify, does this mean we can pull down additional funds that were already available that we couldn't before?
No, what this actually means is if we don't have these things in place, then we cannot draw down the 4E dollars that we have already been drawing down. So it actually will limit us in reduction of those funds if we don't meet these federal regulations.
Well, as someone who works with a lot of transition age youth, this is very exciting because a lot of times kids feel like they're just put somewhere, just put, that's where they go because there's nowhere else to go. And then they lose so many social skills because they linger in that congregate care. So this is very exciting to hear. Thank you for your work on this.
Yeah, I mean, that's definitely the goal, is identifying those youths who, don't really need that level of treatment. That's a big part that we've been trying to already prior to this, step down our need for the congregate care settings, although we have identified that there are some youths that need that higher level of treatment, and that higher level of treatment is necessary for them, at least for a period of time. And so we do want to, acknowledge that our group homes have been working really hard to meet those treatment needs. However, not all the youths there need to continue being there, or maybe even needed to be there in the first place because it might not have been appropriate. So that's what we want to identify that on the front end. Are they even appropriate? But then also once they're there, we want to continue monitoring. Do they need to continue to stay there? Or is that level of treatment need gone down? And if that level of treatment need has gone down, then we want to step them down appropriately. Yeah, I think that's a great point, Kim.
Okay, so we've kind of gone through what this would look like. So either through a PARB recommendation or our staff, we believe that this youth needs a higher level of care to meet their treatment needs. That request then prompts the CANS assessment, which at that time determines either a recommendation for that level of congregate care or not. So if we do place a child in a QRTP placement, now we are at what the ongoing case planning and the roles and responsibilities of our staff kind of looks like. So this is going into the family and permanency team. So we now have this youth in this QRTP placement, and what we have to do, DHS, is we must assemble a family and permanency team for that child or youth placed in that QRTP placement. So this goes back to family engagement and best practice, bringing everyone to the table for this youth to support them in that treatment planning. The team must consist of all appropriate biological family members, any professionals that either we determine as being part of that team or the youth gives their names as well. Teachers, medical, mental health providers, just anyone who has treated the youth or has been involved. And this is kind of a cool piece and really gives some power and lifts the voice of the youth up. But if they're age 14 or older, that team must include 2 members who the youth selects. who's not the caseworker, or if they're going back to a resource home, or we have a resource home identified as their next step in the continuum of care, it's really someone that the youth wants to be part of their permanency team. So this is a big piece, and we're very excited to see this as being part of these QRTP requirements. Next slide. So what are the case plan requirements for the role of the permanency specialist? So for any child placed in a QRTP placement, we have to have reasonable and good faith efforts documented to identify and include all members who are going to be on that permanency team. So we've really been training and talking with our staff through some virtual trainings the last 2 months about this, what they're supposed to do and what their role is. So they need to have updated documentation of diligent searches, any connections that they have found. We need to have updated contact information, because Dr. Wilsie and her team could be contacting some of these connections to be part of that CANS assessment to get some information from them as well. Along with the reasonable good faith efforts to document all members of the team, we also have to have documentation of the parents' provided input to this permanency team. Again, kind of that second point, current contact information for everyone. Documentation of family meetings being held at a time and place that's convenient for the family, including those related to CANS assessments. So we should be having reoccurring, ongoing family meetings, bringing everyone to the table to talk about treatment for this youth. Documentation of the CANS assessment. Again, does it align with that QRTP appropriate placement? And then also, that that last point, we also need to document too, if the family and the permanency team's placement preference was not the same placement setting recommended by the CANS assessment. So Dr. Wilsie and her team do the CANS assessment. We all determine, and DHS is recommending a level E group home. However, the family and the permanency team is saying, we don't agree with that. And here's why. We need to have all of this documented. Having that shared power with everyone at the table when deciding what the placement is and why, really, and how it meets those treatment needs. Next slide. All right, the other piece is the court hearing requirements and determination. So the specialist must provide the court the following. So documentation that the CANS assessment was completed, which has to be prior to the QRTP placement, and then every 6 months thereafter, who remains in that QRTP placement. So you heard Dr. Wilsie hit on that. We're going to do the assessment to determine initially if that level of congregate care recommendation is best for the child. And then if that youth stays there, we have to have it ongoing. We have to have documentation of the youth specific treatment or service needs for QRTP to meet the length of time needed for treatment and services. So short-term goals, long-term goals, how that treatment plan is really going to help support this youth. Documentation of efforts to prepare the youth for returning home or with a placement with a resource family, kin, caregiver, guardian, or adoptive parent. Think of that continuum of care. They're in the group home. We want to get them to a family-like setting. So how do all these things play into this to get them to that next placement for them? So the court must approve the QRTP placement within 60 days of the child being placed there for the state be able to secure that federal funding. We are beginning QRTP, this process with the CANS assessment, October 1st. However, this 60-day court hearing determination will not begin in October, because there are other things that we need to do to get to a place where we're ready for this. And I'll kind of go on about that in our next steps. So as you're reviewing cases, keep in mind, okay, QRTP started in October. There will be a 60-day determination that will be part of this eventually, probably spring of 2022. And what that means is that we have this assessment from the CANS assessment. We have to present this to the court, and at that time, the judge can either approve or disapprove that placement. We have to do this in order to secure the 4E federal funding. So at each subsequent review or permanency hearing, if the child remains in that QRTP placement, the court must continue to make a finding. So when you're reviewing your findings and your court minutes, that the Kansas assessment continues to support the determination that the child's needs cannot be met through placement in a foster family home. So does that court minute and do the findings reflect from the judge that that placement is the best placement to meet the child's treatment needs, that the child's placement provides the most effective and appropriate level of care in the least restrictive environment. So the placement in the QRTP is consistent with the child's short and long-term goals as stated in the child's permanency plan. This should all be from what our recommendation is from DHS. We're recommending the child to stay in this placement because of XYZ. And those findings should be made by the court that they agree that this placement is best for this child because of all the recommendations from DHS in the assessment. So hopefully you guys will start seeing this being documented in our court minutes, review hearing notes that the judge is making, and in the court reports that the worker is providing to the court. I will add that the Kansas assessment will be provided to the court as a social record. It should be sealed, given to the court, and then part of that court file so that all parties will have access to it as well. Next slide. Okay, so we've talked about, we are, training our staff. I said the last 2 months we've been talking with them about this. We are going to start with the implementation of the CAN. So Dr. Wilsie said they're going to start kind of capturing some of the other children who are in TFC, ITFC, enhanced foster care. We are going to identify child welfare district champions. So Maghan Ruark, I mentioned her name earlier. She's currently working on this. She is getting with district leadership, child welfare district leadership, to identify champions who are then going to be trained and become subject matter experts on QRTP so that they can go to the courts and then come together and talk about what does that 60-day hearing look like in their jurisdiction. All courts across the state look a little bit different in how they operate, how often they have those court hearings. So it's really going to be the responsibility of this district champion to work out those details with that judge. So what is that going to look like? Who's invited? What is the procedure of the hearing? How frequently does this jurisdiction want to review the status of a child in a QRTP placement? This all could look different given on that how that conversation goes between child welfare and that district judge. And then how will the review and permanency planning hearings change to focus attention on children and youth in QRTP placements? They are working on this. Again, Maghan is starting to get with the district champions to then trickle to the judges to figure this piece out, because we still do have some time before the court hearing determination will go into effect. So that leads me to that second to last point: enact legislation for statutory changes to fully implement the Family First QRTP provisions in the spring. That court hearing is a part of that. And then continue to work through the Family First QRTP work group to ensure implementation of QRTP for providers, which is in alignment with continuum of care efforts. We do have a QRTP work group that Maghan Ruark leads with providers to talk about everything that we just talked about today: best practice, meeting the treatment needs, identifying any next steps within the work group to align and support implementation of Family First. So we've got a lot of exciting things going on. Keitha, Maghan Ruark, and I presented this to the judges at the July judicial conference. We are going to do a rapid fire training with them in August with the judges to, again, get this information out and hopefully, again, get before them in October, the November judicial conference, just to make sure we are talking about this as much as we can. Keitha, I saw you unmute.
Yeah, I was just going to add to all of this to kind of bring home the point that this isn't really anything new around what the law requires of children that are in foster care around ensuring least restrictive placements, ensuring that they have their needs met, and all the things that we're required to report to the court to make those findings. That's not necessarily changing. What this is changing at the end of the day is allowing us to improve the quality of congregate care settings and the treatment that they're getting in those settings, but also allowing the federal regulations to be in place to be able to draw down those 4E foster care funds. So essentially, we have had the opportunity in our state to be able to delay that court determination piece, because what that means is currently we'll be paying state dollars to fund any child that's in congregate care, because we have to meet these QRTP regulations come October 1st, 2021, if we want to continue to draw down 4E dollars. But we knew because of COVID and the pandemic and the shutdown of the court system, that the court system wasn't necessarily ready for this piece of the court determination, although they technically can order placements now. This makes it tied to those funding streams that we can draw down funds to help pay for kids in foster care. So it's, again, not necessarily anything new that is already and can happen. It's just tying it to us being able to draw down those 4E dollars.
I've got a question. How closely are you guys tied with OCSA with these goals? It just seems like there's some compatibility there.
Yeah, I would say, Jennifer Boyer, she's the administrator of the Successful Adulthood Program. She has been included in this information as well. So those permanency teams that we talked about, when those teams come together to talk about treatment team planning and things like that, could easily see that members of the OCSA team or we have, designated staff in the offices being a part of that conversation to make sure that we're aligning their treatment team goals and things like that to successful adulthood goals as well. So definitely there is an alignment there and collaboration opportunities to really bring everything together for this youth when talking about their plans.
I have a couple of questions. One is kind of related to that. I know that a lot of times some of the OCSA stuff doesn't happen, especially when I say OCSA stuff, like the assessment and the plan for my future and things like that, especially in maybe smaller counties where they don't have a kid that age very often, and so they may not even know that OCSA exists. And so it's not, I guess it's not really a question. It may be more of a recommendation you've already thought of, is how in the future to ensure that this stays kind of on the forefront of people's minds when it's something they don't use very often, or, it's like, oh, I don't need that right now, so I'm going to file it away, and it never comes back to the surface.
So virtual, I'm sure you guys have seen this too, but having virtual opportunities has opened up many discussions for us for trainings for staff, and kind of a buzzword that we've been talking about is like just-in-time trainings. Okay, so you have a kid placed here now. Maybe you've never encountered this before because this is your first kid at a group home. Here's a just-in-time training of what to do. So I could easily see something like that being developed or created for staff who this is their first kid, where they're dealing with, OCSA efforts and kind of getting things done. Jennifer Boyer is the administrator for OCSA, and so I can definitely talk with her about this and kind of see maybe we can do some collaborative efforts with QRTP with OCSA. We're continuously working on training with our staff, especially with staff working from home now. There's kind of been maybe some information that newer staff aren't just quite aware of yet. So I'm happy to take that back to Jennifer about that, kind of what you're seeing. And if it's in specific kind of places, we can definitely add some extra, trainings and things like that for staff. So.
Well, I don't know that I see the two as kind of similar. They're both things that you don't, always use all the time. And so if you've not had a kid in congregate care yet, or you haven't had a kid in that age group, it's just things you may not even be aware of. And like you said, when you're not in the office and you don't overhear conversations and you're, not aware of some things in the background, you may not know. So the just-in-time training is a great idea. I love the idea of that. The other question I had was, I like the focus around the kids having someone that's their people, that's not a foster parent or the worker in the meetings. And we see a lot of times the kids who've been in care for a really long time, they just don't have people. They've broken a lot of connections that they may have had, and their family's completely disconnected. Is there a way for the permanency staff to work around that requirement? Is that something that's going to become a burden for the permanency staff?
So I would say that as we've been gearing up for Family First and trying to really emphasize to staff about connection finding and things like that, we had them take a training this last spring and summer about diligent searching and connection building. Part of the training was, on average, every child in foster care might have between 200 or 300 connections. And so if you kind of do the math, those living, adult, and things like that, we kind of got to a place in what we're saying is that every child in foster care should maybe potentially have at least 100 connections. So I think that our staff, we have a lot of work that we want to do to continue to build connections, getting them to creatively think about who they could talk to be a connection, not solely focused on just placement, but rather supporting this youth. So we're doing a lot of work there. But at the end of the day, I know, must have, if the youth is saying, I don't have anybody, that's certainly, I don't think, a sticking point that we're going to make, because then we don't want to make them feel bad too, because if they don't have someone. So I would say that's just, we're stating that as best practice to really get our staff thinking about that and helping them support the youth and identifying connections who are important to them.
Thank you.
Anything else? Keitha had on that last slide our emails and our names, not for confusion, but Maghan Ruark, Permanency Planning, and then Maghan Wiss is over the continuum of care. We get confused all the time, so it's okay. But please feel free to reach out to any of us if you have any additional questions.
I told them at staff meeting this morning that we were being trained by 2 out of the 3 Meghans in DHS.
Yeah, she wanted to be here today, but she had some other things she had to attend to. So
I understand. Well, and I wanted to jump in earlier what Kim was bringing up. I mean, obviously, what's going to be the priority for staff and administration is what's tied to funding. And that's not a bad thing. We all have to do that to keep our doors open. But so I think that's going to help with that too, which I guess there's really, is any of the Family First stuff and the 4E money, is any of that going to be related to OCSA? I mean, is there any hoops that need to be jumped through there?
No, not in direct connection. They have their own funding through Chafee dollars. Certainly, we have seen an increase in different federal regulations around some of those changes, which Jennifer Boyer could definitely come and probably talk to you guys about the details of any of that. But in terms of this kind of placement setting and the federal regulations around that, no. I mean, it will only add value to ensuring that we're meeting the needs of the children in those placement settings when they're of that age requirement to start working towards those goals of independent living, but it doesn't negate or tie it to the funding per se.
just have to make sure that the new stuff rolling out is closely tied and connected and coordinated with OAKSA as much as possible. And of course, you know, my perspective, and it's totally anecdotal, is that OAKSA is wonderful and it's underutilized, under supported, and I mean that in a, it's just complicated to do, just like all older kids are complicated. Anyway, and I don't hope no one took that as a slam. I don't mean it that way. Just anything we can do to enhance OAKSA, I think we should. Right, Christina?
Okay. Well,
Any
I
other
guess-
thoughts, questions from anybody? Well, I got several emails, by the way, of folks that were very interested in this presentation and couldn't be here today. So they'll be anxiously waiting for the video. So.
And if any questions come up along the way, certainly our contact information's on there. There's lots of parts to all of this and different administrations, but we are all happy to connect internally. If you end up emailing one and really need the other, we'll make sure that happens.
Right, and I'll email out the PowerPoint as well. You know, and as always, we sure appreciate the partnership with child welfare, both on the highest level and with state, like with you all, and with individual workers presenting their case information at our local parks. That every time I go out to a local park board and you know, some young scared ladies presenting the case information, but is really supportive of our efforts, and that's always really nice.
And I'll just put a plug in if I can, Keith, for those that are here in person. I know some people might be interested more on that prevention provision side of things, although we talked specifically about how this court piece is tied into your roles. We will be talking further about that at the stakeholder meeting at the biannual group in October with the Department of Health. That we have began having with them the last couple of times that they've been having those. And so it's October 14th. We don't have a time set yet, but I'll make sure that I'll send you the invite, Keith, so you can send out. But that's pretty much open to anybody that wants to participate and hear about all the prevention efforts going on in our state as well.
All right, thank you very much. Anybody else? Any last thoughts? Okay, well, thanks again. Appreciate it. And we'll see you all soon.
Thanks.
Thank you, guys.